So we're going to kind of get going tonight. Sorry about the room confusion. They're doing some reconstruction through the Health Science Center, so we're going to be down here tonight. Next, starting in 2017, we're going to be moving to a new room upstairs. It'll still be in this academic classroom building. And we'll send an email out and tell you where it's at and all. But I think y'all are going to like it a lot better. It's going to have light a lot better. You're going to be able to see the screen. And we're going to work on using interactive television a little bit more. So welcome everybody to tonight, to the last case review for 2016 for December. Tonight we're going to discuss hypothermia, being we're in that season of the cold. And guys, this is something that at the end of the day we don't see a lot of. We don't do a lot of this protocol. And so it's important for us to revisit these things from time to time, especially when we come into that season of different care. And because it does change the things that change the way we take care of some of these people, especially during cardiac arrest. So Alan was very nice and kind and let us borrow one of his pictures for this presentation. Is that not it, Big Al? So some of the things we want to talk about tonight is we want to understand the different causes of the systematic hypothermia. Because we think about it's just cold weather, but it's not just cold weather. We've got a lot of different options, or a lot of different causes of this hypothermia. So we need to make sure that we're including these non-environmental sources that we may have, things that we can do to prevent and provide better care for our patients. We also want to examine the pathophysiology behind hypothermia, what's causing it, what are the risk factors associated, and especially with prolonged cold exposure. We do have a large homeless population. And turning into this time of year, we did have several deaths that were associated with hypothermia last year. So we want to make sure that we're covering those things. And we're going to look at our pre-hospital interventions and things that we need to do during arrest and how to take care of these people properly. So we're going to talk about, first of all, about accidental hypothermia. So accidental hypothermia occurs unexpectedly and uncontrolled. So guys, this is one of these things that it's not just about the temperature, but it's what are the elements with the temperature. We got to start thinking about the other things like air. Did we have wind with that cold? Is there water, moisture, snow? Are they submerged? What other things do we have? Wind speed is a big thing because that, as we all know, working out in that, especially during July last year, what that did to all of us. The ability to move and shiver. We don't think about that a lot, but do I have the ability to shiver? Because that's my body's natural way of warming myself up and taking care of myself. How long were we exposed to that cold, and what protection did we have, or if any? Or is, once again, is it a homeless person that was living in a shelter, so they were blocked from the wind, but they were still getting wet? So we have to kind of weigh those options and see what all we have together. So the environment doesn't have to be freezing all the time. When we think about these things, this chart below is going to start talking about water temperatures. And we start talking about those things that are at 32 degrees, so we're just getting into the freezing point, not quite. But we think about exhaustion and unconsciousness. Then we've got to think about, after an extended period of time, can we survive this? So as we talk about the water temperature at 32 degrees, it doesn't take long for us to get exhausted and unconscious. Well, if you've got somebody, once again, that's maybe homeless, or maybe an elderly person slipped and fell outside. They're going to pick up the newspaper. They're going to take the trash out in the backyard. So there's nobody seeing them. It doesn't take long for the elements to start to feed into their illness. So not only are they hurt or they injured, we're going to talk about adding that to that. But now we also talk about the things, and it may have been that it's raining outside on them, or they fell into a small puddle of water, or it may have been they fell into the in-ground hot tub or a swim pool in the backyard. You don't ever know what could happen. But then those water temperatures, when they come up to 32 to 40 degrees, and guys, for any dive guys here, no dive guys here tonight, they have to play, this is a huge factor in for them. Exactly, especially when we talk about rescue situations. That's something that you as providers also have to think about when I'm rehabbing those guys. What is the water temperature like, because what's it going to do to them? At 32 to 40 degrees, it only takes 15 to 30 minutes and they become exhausted and then move into unconsciousness, and at 30 to 90 minutes it's probably not going to be survivable for them, and it all depends on with what they have. Now Al once again provided a picture of him doing the Polar Man for us this year, but as you move on up, guys, you start thinking about water temperature 60 to 70 degrees. Okay, so a couple of 7 hours, they can tolerate that. And then they become exhausted, but you've got to also add those comorbidities, the age falls into play in this. So guys, you don't always think about that it's freezing, because even here, if water is 70 to 80 degrees, that's pretty comfortable water. But over time, that's going to cause us to, and that would be a very prolonged situation. I can't think of anything in West Texas that would, you would think about maybe a boat sinking, maybe down in Alley Henry, them treading water. Surely you could swim ashore in 7 hours. Now I would give up and just probably die because I'd be exhausted. But somebody could probably swim ashore. But we don't always think about this even warmer temperature, but it can cause us some issues. So the second cause of accidental hypothermia is we start to talk about the impaired thermoregulation. And this is where we start to think about these other factors that come into play. Because how many times does somebody just have maybe a beer or two, or they chose to use some drugs? And when I say chose to use some drugs, it could be their own prescription medication. Adding beta blockers in, adding calcium channel blockers to the plate, ACE inhibitors, angiotensin 1s, angiotensin 2s. We've got to think about all these things and these effects, because it's going to affect how we deal with things. The simple thing on drug use we think about is a simple angiotensin 1. So we add lisinopril to the mix. So at that point, what's the number one thing the body's going to do is vasoconstriction, trying to provide warmth. So they're going to start to shiver, going to start to vasoconstrict. They've lost the ability to do that with just a simple drug of lisinopril. Severe trauma with or without head injury. We're going to talk more about the trauma here in just a little bit. But then we have, septic shock. It may be, Granny's got a little bit of a cold. Or she may have the flu, but the trash has to be taken out. She thought today was the best day to do that. Started walking outside, tripped, was not really injured, just unable to get up. We see that all the time. And then we start to add this sepsis into this. Geriatric population, once again, chronic disease. You have neuropathy, diabetes, whatever it may be, poor circulation to start with, PVD, cardiovascular disease. We have all these issues that come into play. Certain drugs and medications, once again, such as beta blockers, calcium channel blockers. We don't think about those things playing into effect, but we're going to talk more about that as we get through this. And then the response to shivering. Do I have the ability to shiver? Is it decreased? Is it decreased because I'm unconscious now? That plays into that factor. But we also start to talk about a lot of your elderly people. What do they tell you all the time? I'm cold. And so that's because that hypothalamus comes into play. Then we start talking about our young. And so we have a very underdeveloped hypothalamus in our young folks. We always hear that, somebody's not dead till they're warm and dead. Well, with children, it's even more so true, because our children just do not tolerate the cold very well. Infants do not have the ability to shiver. Infants don't even have that capability to shiver. They rely on their brown fats. Those brown fats provide that warmth that's needed for those infants, but once again, they don't have the ability to shiver. So let's talk about the epidemiology report. So 1999 to 2011. And what they determined is that the cause of death directly related to hypothermia was 16,911. That's an average of about 1,300 a year, and 67% of these were males. So we already lost that again, guys. Driving, men are more likely, 60% to have an accident. You're more likely to freeze. Why is that? I don't know. You're probably more likely to be out in it, and because the ladies are smart enough to stay inside where it's warm. This is a real problem. This is something we see. It's why I had to write a protocol specifically for hypothermia. But once again, we don't visit it a lot every year. Thank goodness. But when we do, we've got to be on our A game for that. So how does the environment still our heat? And there's several different ways that we talk about this. And first of all is radiation heat. This is one of these things. This has caused the most significant heat loss. This is just general, I'm not protected. I don't have anything, my head, I don't have any scarf over my head. Now, some of us in the room have less hair than others. And that's one of those, parts where they have a little bit of extra warmth on top of having the hair. Not saying that they're going to stay any warmer, but that's when toboggan. Your mom always said, put your hat on your head, keep the warmth in. You lose a lot of radiant heat through just not having things properly covered. Then we start talking about conduction. And conduction being from You go to a football game in December, you sit on the cold metal bench, and you get up, and what is cold? My honey. And it's very cold. And a lot of times it takes a long time for that to reheat. But in saying that, water is 30 times greater than air of taking heat away from us. So anytime that we're in a submersion type situation, even if it's Granny fell in the backyard into a puddle and it's raining on her, she is going to cool a lot quicker at that point, about up to 30 times faster than she would in normal situations. Then we start talking about convection. This is about 15% of our heat loss. This is where air moves through. And guys, we've talked about for years, talking about as soon as we deliver a baby, what happens with that cool air floating around. It's going to start cooling that kid very quickly. So I need to make sure that I've got that, the air turned down at that point, and the baby's protected. Keep that baby wrapped, keep that baby covered. Evaporation and respiration, this is a very small amount, but we still can lose some temperature through just general breathing and through evacuation. So the body's response to the cold. Core temperature is tightly regulated by the hypothalamus. This is a thermal neutral zone. So typically we like to our bodies stay between about 97.7 and 99.5, somewhere in that neighborhood. But the first response for our body is to vasoconstrict. So the very first thing my body's going to do is start to squeeze everything, which makes good sense because when I'm sitting out hunting or I'm watching that football game and it's cold, my body starts to squeeze everything. So what's the first thing that goes cold? My hands and my feet. It makes good sense. At that point, but then we start thinking about the drugs that we have associated with that. Maybe our vasodilation drugs, or maybe our angiotensin 1s, angiotensin 2s, calcium channel blockers, beta blockers. It comes into play here because just the simple things of, I have an elderly patient who's on lisinopril and DIG, and now I've got to go, not only are they cold from just the radiating heat, they've been convecting heat, we've had air blowing on them, they may be wet, but on top of that I have my drugs into play that doesn't allow their body to do the natural response of vasoconstriction. So this is going to magnify that hypothermia. So the body is controlled by the hypothalamus. That's what controls all of our temperature, to have the ability to shiver, that initial drug response of epinephrine, and to start to allow that metabolism to get going. That epinephrine is going to squeeze, just like we give it during cardiac arrest. My body's naturally going to start squeezing, and so I'm going to start to move that in. Shivering is caused from muscle contractions through that. It increases the rate of heat 2 to 5 times than resting muscle. So as you see yourself, you get out there first, you're out doing something in the backyard, you're working for a while, and all of a sudden you get the shivers. You'll get a little bit of a chill, and that's your body trying to create itself its own natural heat. It's all driven from the hypothalamus. As these levels of epinephrine, I'm going to get some increase in heart rate. So my heart rate's going to be picking up. That's going to be saying, hey, I've got to do something here to make this warmer. I've got vasoconstriction going. But once again, our medications on a daily basis have a higher risk factor for us putting us into this. Once again, beta blockers. Beta blockers bluntly affect the usage of our epinephrine that my body naturally does. So I'm not able to get that squeeze. Whether I'm using the beta blocker for rate control, hypertension, whatever it may be, this is going to come into play with what I can do. So as I start to drop that, my body recognizes it and says, hey, I need to initiate something. So that's when I start to get the vasoconstriction in place. At that point, once I go 1 degree Celsius past that point, that's when I start to shiver. This is a last resort for my body. So we always think about pulse oximetry being, okay, I got pulse ox, man, my pulse ox is 99 during intubation, and it's 86 during intubation, and it's down to 76. That's way down. That's the last thing you're seeing is a change in my pulse oximetry. It's the same with this. Once I start to shiver, this is my last chance of my body to start to generate its own heat. So we need to be aggressive. If we get there and we see people shivering, we should know we're further along this process than we should be, or we think we are. So once again, as we shiver, this increases our heart rate up to our creation of heat up to 5 times, but it increases also glucose and oxygen demand by our body, which is normal, that makes sense. But shivering then, it ceases, the core temperature is going to start to drop, multi-systems trauma and comorbidity. We've got to think about the things, okay? So does the patient have a CHF and they're in stage 4 renal failure with it. So we've got all these issues playing into Granny just fell in the backyard and it's 40 degrees. And then all of a sudden somebody comes over and checks on her 3 days later and she's laid out in this. So we've got to add that into what's going on along with what is wrong with her. Then we talk about our impaired consciousness. So say if we do have a traumatic brain injury, fell and hit her head with it. And so we've got to think about those options because now my body, the hypothalamus may be affected. And so now the whole time I've not been able to help drive my body's natural drive to control the heat. Analgesic that people are using at home, very bad problem as we talked about. Alcohol intoxication, sedation. All of these are going to suppress our CNS, so that's going to increase that probability that I'm going to have more trouble with hypothermia in the field. So it's too cold, and once shivering stops, now what? Well, here comes the vicious cycle. For every about 10 degrees Fahrenheit that our body decreases the core temperature, the chemical production of each cell drops in half. And I'm getting myself in more trouble because now I'm not shivering. I don't have that, I'm not able to use that, and that's when we start to have that cell death. As part of that, that's when we have all of our vital organs start to shut down, and that process starts to take off very quickly. Once our core temperature drops to about 94 degrees, this is where we start to get in that critical zone. We don't think about that because our cardiac arrest, what are we going for? We're trying to get them to 92. And so when we think about it, we're actually putting them in a hypothermic state, which is good, but not good in the normal situation of everyday life. This is something that we don't want hypothermia right here. So the body's cold. So what systems are affected? We talk about our CNS. The temperature at about 33 degrees Celsius or 91. The brain electrical function is abnormal at that point. So you get there. It's somebody you found outside. They've been outside for a long time. They're confused. You think, are they anoxic? You've got all these factors into play of what's going on. But you should know that once they get an abnormal brain function, that's at about 91 degrees. So we know we're below the 94 threshold. We're already getting in trouble. But then when we start talking about, once it starts dripping down into the 66 and 68, this is where I can start to have, the EEG will actually show brain death at that point. And so that's a hard part, especially men in the field. You've got somebody that's breathing, that's got pulses, but they are totally unresponsive. You probably know we're very behind the 8 ball now. We got to weigh that. Is it drug induced? We had to add all these things together, but if they've been out in the cold for a long time, we have to use that. Cardiac, decreased depolarization. This is where we start to get bradycardia. The SA node finally says, you know what, I can't do this anymore. It starts to brady down. I lose that ability to I get an AV block built in at this point. Atropine's not going to do us any good here. And so with our cold patients that are bradycardic, I'm in trouble. I'm in a lot of trouble. We know that electricity is not the best thing for them. We know that drugs are not the best thing for them. So really the only thing you can do for them is fluid and heat them up at the end of the day. And so we've got to do that in a slow process that we'll talk about. So pediatrics, the main thing we need to use is level of consciousness. Where is that pediatric patient at? Once again, our infants do not have the ability to shiver. So they have brown fat. And they have large concentrations of brown throughout their body to help keep them warmer in those spots. And so the body naturally has that built into place because they just can't shiver. And so I have to take that into place of saying, man, this kid's really cold, but why is my kiddo not shivering? And so it's one of those things that they just don't have that ability. So I've got to recognize that, and so I'm going to have to be really aggressive with those folks. So we start talking about cardiac activity with our hypothermia. This is where we get our fight or flight. So initially, I'm going to have that dump of epinephrine. I'm going to increase in heart rate. I'm getting to my fight or flight's kicked in. I'm moving forward with this. So my body's doing its thing like it needs to, but then as I get colder and I get colder, I start to move into that bradycardic state. And so I lose that ability, that sensitivity, the catecholamine release, my vasoconstriction is gone, and so I no longer have that ability to keep that heart going. As the hypothermia once again progresses, tachycardia turns into bradycardia. And we've already talked about the epinephrine's not going to work. My catecholamines are dumped at that point in my body. I don't have that ability. And so that's why when we talk about our H's and T's in cardiac arrest, one of the H's is hypothermia. I need to start correcting that as part of an H and T as much as possible. Now, our cardiac arrest, at that point, we do want them colder, but we don't want them hypothermic. So, if we're below 92, we need to start aggressive warming measures. Once again, nobody is dead till they're warm and dead. And you hear that because I've lost the ability to have muscle contractions at that point. My heart has lost the ability to contract when it's hypothermic. And so that's why we have to warm that body slowly to warm it up. Guys, we've seen arrests that we've worked and brought them in, and they're working for another hour and 20, hour and 30 minutes in the ER, trying to get those people warmed up to see if they can get some electrical activity going. So some of the hints that we're in some hypothermic problems. Now, some of the older medics in the room, y'all learned Osborne and J-wave. So a lot of y'all this makes good sense. The new folks, they don't call it an Osborne or J-wave quite anymore. This is where we start to talk about the differences in our 12 leads. And this is why it's important. They may not show in all leads, and that's why we need to do a 12 lead on these patients. We'll start to see our Osborne and our J-wave start to change. Here you see in ABF, I've got more of just a sloping, when here I've got a prominent J-wave. And then again in B6, I've got a dip almost into the J-wave, but not quite. That's why it's important to run a 12 lead with our patients. As you can see, there's the J-waves there. It's not really present in your ABF. Take another look in here, once again. As you talk about, you've got a full elevation, so you get narrow complexes. But you can see that my normal isoelectric line, that's probably what most of the young folks in the room were taught, is isometric line, or isoelectric line. But you've got definitely a prominent J-wave at that point, once again in multiple leads. As we talk about the Osborne wave, one of the things that we talk about, this may be prominent in people with normal core temperature. So some of the other things that we can see with this is certain medications such as cocaine can cause this. And intracranial hypertension, severe head injuries, we may see it too. But it's one, again, if I've got a patient that I found out in the cold and they got a J-wave, I probably know I've got some cardiac issues going on and I just don't have now could they have a head injury with it and that could be causing it? Sure. Or they could use cocaine, hit their head and laid out in the cold for a long time. Then you got three monsters to fight against. So some of the things that we talk about, in a warm room, some examples, we talk about cold sepsis. These patients can get hypothermic. They can drop below, remember our Sears criteria, 96.4, and I've got them cold at that point. They have fallen into a mild hypothermic state at that point, and they're cold sepsis. The vasodilatation is very great. They've lost the ability to squeeze. We talk about our hypoglycemia. Once again, if these people are hypoglycemic and outside, or just in a cool room, they could get a little hypothermic at that point. Diabetic ketoacidosis, once again, there's plenty of sugar available, but there's no insulin. So they can't use that fuel to shiver anymore. They've lost that ability, so it's things we have to think about to add in to the hypothermia. So in general, the things we need to talk about is prevent any further heat loss. That makes common sense. If I pick somebody up and they're wet, they've been out in the cold, I need to get them out of their wet clothes. I need to get them into something dry. I need to get them wrapped. I need to turn the heater on in my truck, and that's not always the most comfortable thing for me. But it's not about me at that point. It's about doing the right thing for the patient. Yes, we'll get at the hospital, and you've sweated, you've been just profusely sweating the whole call. You finally get to the hospital, where do you take them? Into a hot trauma room. And it's even more miserable at that point. But something we've got to do is prevent any further heat loss. Rewarm the body at the core temperature. We're going to do this very slowly. We're going to look at this in the protocol. And then we want to avoid precipitating VFib and malignant cardiac problems. And so one of the ways that we have to do this is we have to move these patients very gently. We don't think about that, do we? Because if we pull up and somebody's unresponsive they're breathing, they have a pulse, but I'm talking sternal rub, which is probably not the best thing for a frozen person, because once again, I need to be gentle with them. But as that process comes in, I need to be careful moving them. We don't always think about that process, but it is something that we've really got to take care of so we don't irritate that heart and put them into V-field. We want to be careful with the way that we're moving them. Get them to the truck very quickly, as quick as we can. Get them out of those elements, but we want to do this in a gentle way. Lidocaine and other antiarrhythmics, amiodarone, these may not be effective. They're not going to circulate well. When we're cold, what is our blood? It's typically thicker. And so it may not circulate as well, especially when I'm in a cardiac arrest situation. And so I'm not always able to give all the medications during cardiac arrest. So stop heat loss. Once again, we want to remove any wet clothing. We want to stop the after drop. This is where we start our warming procedures. We get vasodilatation going. We allow cold blood now to circulate from my posterior aspects. So I got my arms and my legs. I finally start to warm up. I get vasodilatation. I start to get flow. Then I get a circulation of cold blood. That's what we consider is our after drop. And so that's the process. We're now going to be fighting that hypothermia all over again from a different cause. So pre-hospital management. We talk about getting wrapped. You know, most people during the wintertime are making winter cots. As part of this winter cot, something we need to think about is a rescue sheet or other vapor barrier devices. And this is where this actual study was done, and it talked about, so the person was in wearing cotton clothes at 5 degrees Celsius or 41 degrees Fahrenheit with a 6 mile an hour wind. 6 mile an hour, that's not even a wind in West Texas. That's just starting to get to a normal day, a light breeze. So what did they find? A blanket, they used a blanket only. They used bubble wrap, which is something they use in aeromedical in Europe a lot. And then they used a plastic sheet and a blanket over it. As part of this process, the blanket and the sheet, the plastic sheet, showed great improvement with heating those patients up. So that may be something we want to think about, is adding that to, we already carry it on the truck, and so we can go ahead and use that, and that may help warm those patients. If the patient is pulseless, we need to start CPR procedures. That's just it. We have to do that. We're going to follow our ACLS protocol. But the big change is the attempts with defibrillation and medication administration. This is something that I need to back off on, because a cold heart is not going to accept the drugs like we normally are used to in a warm situation. As we start to give these medicines, what happens is a lot of these drugs will pool. So they'll be left in the peripheries because they're not circulating. And then once I get vasodilated, when we warm that body, because they're not dead till they're warm and dead, and they start to warm it up, then all of a sudden you get this huge rush of all the drugs we've given, because now you finally got circulation. So that's why we cut those protocols down. As you can see, it's defined in our protocol to talk about severe hypothermia. This is anything less than 86 degrees Fahrenheit. They get 1 defibrillation and 1 epinephrine, and that's all. No more repeat after that. So if we don't, that way we don't have that buildup of medications in the system. We know that electricity is not going to be used by the heart very well at this point, because like we talked about, that heart is not contracting like it needs to. So the defibrillation is not going to work. The mild hypothermia. This is between 86 and 93 degrees. Now, it's one of those that the protocol is indicated we should use longer intervals, but we can repeat the doses. So this is made where I give the epinephrine, I give it once every 10 minutes, because it's still taking that time to circulate. So the question is, how do we know we're there? How do we know what temperature we're at? Rectal thermometer, okay? And guys, this is one of those things we don't use like we probably should with our cardiac arrest patients, but in a cold situation, it's imperative. We really need to get that thermometer in place. So I'm sorry if you're the youngest one on the truck, you're probably going to get that. You're going to have to do that skill.
Or a fireman.
He threw y'all under the bus on that one. And then we start talking about our hypothermia protocol with a pulse once again. You know, where are we at? That's once again, even on our unconscious patients but have pulses, if we think it's a hypothermic situation, I really need to get a rectal thermometer in at that point. Glucose, so important. We've got to have glucose present. Now, If we're not making insulin and providing that, then I've just got a bunch of glucose there with no insulin to use it with to turn it into usable. And so my ATP is going to start dropping at that point. Airway needs, supplemental oxygen as appropriate, cardiac monitor with a 12 lead. Now, the IV procedure, guys, we need to get them with some fluid bolus. And then keep an eye on them for rewarming. You know, one of the biggest things, we've got to talk about our neurological status. That is one of the biggest factors here to come into play because it tells me my body can shiver. That tells me that I'm making the epinephrine, I'm squeezing, I'm doing the things that my body needs it to do. Heart monitor, we talked about the 12 lead, very important, so we can try to track these to see do we have an Osborne or a J-wave at that point. Once again, our cardiac arrest talks about, well, first of all, handle your patients very gently. We want to make sure that we're being very careful with them because of dysrhythmias. Our cardiac arrest, once again, we've got to follow those protocols, and then it breaks it down as we've talked about. Antiarrhythmics and pacing may not work in these patients with core temperature below 86. We've talked about that. So we've got to do the things. That's why we've got to rewarm these patients slowly, and I need to notify the ER as soon as possible so they can get a bear hugger, so they can get the room heated up, they can get warm fluids ready to go in a transfuser, and we can start those processes as soon as possible. So let's talk about the hospital management, because we really don't talk about this a lot, but one of the biggest things is they move them into ECMO. And as we move them into ECMO, is what they do is they go through the femoral area, they warm, they reoxygenate the fluid, they clean, the blood, they clean it, they heparinize it, they put it back in the system. Now this is not dialysis, they're not filtering the blood at that point of all the nasty stuff that from our kidney patients that they can't filter themselves. But it's what it does is it rewarms that blood, and that ECMO it reoxygenates it, and they get heparin to get it thin. Remember, during cold times, my blood is usually thicker, so I'm not moving quicker. So at that point, that's how they're going to start taking care of it at the hospital. So they may be moving in with an ECMO machine very, very quickly, especially if you get ROSC in the field with somebody who's very cold.
VA ECMO is often performed using peripherally placed cannulas, typically placed in the femoral vessels. This animation shows arterial ECMO access in the femoral artery. With extreme cardiac dysfunction on ECMO support, if the heart is not beating and the aortic valve is not opening, the blood being pumped through this cannula provides 100% of the patient's blood flow. In this scenario, there's no mixing of the two circulations since no circulatory support is being provided by the native heart.
Okay, so let's talk about, they got a call, and we need to look at a case during case review. So they got a call, and they found the patient who was sitting on the snow and ice, yelling incoherently toward the house in the street, was just yelling. The clothes were inappropriate. Guys, great documentation because they're leading up to the patient wasn't dressed properly. We found him on snow. We found him outside and they're incoherent. Now, how many times have we seen this? So we're all thinking drugs, you're thinking da-da-da, you're thinking alcohol, you're thinking what's going on today? Is it blood glucose level? But after what we talked about, we know that incoherence comes into play, and so that may be playing the factor here. So I can't just chalk it up to that it's something else. Now, good thought process is I'm going to go through everything that I've got to make sure to see what's going on. No obvious signs of trauma, so that relieves some of that. And the patient refuses to speak or cooperate, says they want EMS to leave with using some choice words toward EMS, which is, in fire, not uncommon. You've been called everything in the book. And so no unchanged behavior before, so they call 911. No history, no allergies. Once again, just documents. Hey, they find the patient slurring their words. We've got some eye ticking. So now we're thinking, well, maybe this is drugs, but this still could be our cold related. They've done a very nice job, once again, documenting what she had on, what the patient was, the conditions outside, cold, not dressed appropriately, so this could get us into some problems. Once again, talk about no signs of cyanosis, did a great job leading into really painting a great picture of what was going on. So we finally make the decision we're going to be able to transport this patient uncooperatively. We understand decreased LOC, so really not able to get that. Pressure is 142/88, heart rate of 110. So we know we're to that elevated heart rate, so we're still way ahead of the curve here because we haven't started the bradycardia portion. So we kind of start to weigh these things together now. Tachycardia at this point, I could be thinking drugs still. Okay, not uncommon, not a bad thought process either. But we've got to weigh, kind of what's going on and what's happening. So once again, the oppression, assess delay upon LPD arrival, because LPD was talking to him first, and then we moved in. We got layer blankets blowing, and then warm air blowing. They're very aggressive talking about, so basically the boyfriend said, hey, I locked her out of the house. She's been outside for a while. She probably is cold. Maybe she was being ugly to him or he's being ugly to her, who knows. ECG, IV blood draw, did a great job really documenting rewarming procedures are in place. Remember guys, we're not there to rewarm them immediately. This is a slow process, maybe over a couple of hours, even once they get to the hospital. So using a bear hugger, those things. Sinus tack, but they also noted here the shivering. So we know we're ahead of the ball game here. We have shivering present. And so that's going to make it hard sometimes for us to get a 12 lead. Understand that. So you may not be able to see that Osborne or J-wave. They get an IV established, give 250 bolus, get blood draw on. Once again, vital signs are doing well. She responds well to the 250 bolus. So it tells me, okay, I'm stressing, but I'm able to start correcting some of that. So, and guys, Dr. Troutman wasn't here. He's in the process of having a new baby tonight. And so he wasn't able to make it so him and his, I guess you probably need to be there for that. So he's there at home with his wife. So Dr. Troutman's take-home points were, look at yourself. If you were cold, is the patient cold? If you're standing out taking care of them and you're like, dang, it's cold, I've only been here for a few minutes. What are they like? And so you got to start thinking about those things. If you stood in the trauma bay where you took your clothes off and the patient was freezing, they delayed covering you up. EMS probably does a better job at this. So lots of times you go see them. They get to the hospital, what's the first thing they strip them? They're not always the best about getting them covered up. So guys, we may have stripped them in the field because they might have been wet. So I need to make sure that I'm getting them covered up. I'm doing a great job getting them covered up, and especially dealing with somebody who's intubated, altered level conscious, or a young patient. Guys, this happens all the time. We roll in those bays. I understand those rooms are warm, but you still have that radiant air blowing around. You have people walking by, especially on our kiddos. With just a walk by, you get that cool breeze that falls on them. And so, then you think about they take them down the long hallway at EMC. What's that long hallway? It's the tunnel. It's nice and cold. So you got all that cold air blowing. You got to think about those things when we're transporting these patients. Although the Osborne wave is a neat finding in the ECG, it really doesn't matter a lot clinically. It's very hard because once again, they're shivering. You may not get a good 12 lead, but the basics is use your thermometer. Use your thermometer at the end of the day. I understand, rectal's not the, you're kind of, okay, he's going to do it, paper, rock, scissors. But if they're conscious, let's do a tympanic. But if they're unconscious, moving into cardiac arrest, I really need to get a rectal. It needs to be a core temperature at that point. I would like eventually if the esophageal intubation or the esophageal temperature probes are great tools we could use. Point number 3 was remember that your patient is found down, quote unquote, in a cold climate. Treat the cold issues, but don't forget to explore the reasons why. Is it trauma related? Is it glucose related? Is it drug related? Y'all do a great job as detectives, and that's what you've got to do in the back of that truck to figure out what's going on.